So one of the things that's come up is the idea of ivermectin. Ivermectin is this medication that was initially studied. Came out in June of 2020. And what they found was that in high enough concentrations in vitro in a test tube, when they went to something called 5 micromolar concentration, they were able to completely shut down and reduce by about 5,000-fold the ability of the SARS-CoV-2 virus to reproduce. And so obviously there was a lot of excitement because perhaps we might be able to use a repurposed medication like ivermectin, which has been around for years and is used as a antiparasitic or antihelminthic medication, especially in South America and Africa. Perhaps this could be used to treat COVID-19. This paper, which was an in vitro paper looking at 5 micromolar concentration that was required to shut down, was one of the things looked at. The problem is that when you look at the actual dosing of ivermectin in a human being, you only get about 0.28 micromolar. So that's a number of orders of magnitude, if you will, reduced than the concentration that you would need to have in the cell to get that. And so this paper here that was published in the British Journal of Clinical Pharmacology said that the free plasma concentration of ivermectin was actually 250 times lower than the concentration required to reduce viral replication of SARS-CoV-2 in vitro. But again, this is all in vitro, and so we look at actual randomized controlled data and meta-analyses. And there was a meta-analysis that came out in June of 2021 titled Ivermectin for Prevention and Treatment of COVID-19 Infection, a Systematic Review, Meta-Analysis, and Trial Sequential Analysis to Inform Clinical Guidelines. And what they did was they looked at a number of different studies. Some of them were randomized, some of them were not as well randomized, some of them had bias, and they analyzed all of those things. And they came up with the conclusion that there was moderate certainty of evidence that there was a reduction in death compared with no ivermectin. But the rest of the conclusions had a very low certainty evidence. Now, this meta-analysis included a randomized controlled trial that was later retracted because there was basically fraud going on in the study, although that hasn't been fully investigated yet, but it seems as though there were some problems in that study. The authors of the meta-analysis say that it wouldn't have changed the overall conclusion, but you can kind of see that there are some questions. And a lot of these studies were done in patients that were in basically outside of the United States. And why would that be an issue? If you think about this, ivermectin is a medication that kills off parasites. And if you look at some of the data in, for instance, in Egypt and in the Middle East, South America, the amount of clinically silent parasitic infections in the population approaches in some studies 50 to 60%. So you can imagine if you take these patients who then come down with COVID-19, put them in the hospital and apply to them large doses of dexamethasone, which is an immunosuppressant, it's possible, we don't know for sure, but it's possible that some of these parasitic infections may be becoming less silent and becoming activated with the suppression of the immune system. And so it makes sense that in those types of situations that adding ivermectin may be beneficial, not because it's helping out COVID-19 specifically, but because it's suppressing these concomitant infections that are going on. That is a potential possibility. And so if you're asking about whether or not ivermectin should be used in the United States, what you really need is randomized controlled trials in the United States, looking at the United States population. And right now, I'm happy to say that there are a number of studies that are undergoing, not only in the United States, specifically at Temple University in Philadelphia, but also there's a trial that's looking at McMaster University and also in Brazil called the Together trial. And what they've done is they've actually made this platform where they can rapidly assess the efficacy of repurposed medication. So things like hydroxychloroquine was looked at. That didn't find any improvement, so they stopped that study. They looked at lopinavir, ritonavir, and they stopped that study because there wasn't improvement. They stopped the metformin study because there wasn't improvement. But there are 2 medications that they're currently looking at. They're looking at the ivermectin single dose to see if that is causing any improvement. But the one that they're noticing actually has an even better signal that they're studying more is fluvoxamine, which is a antidepressant medication. It has some claims that it may be an anti-inflammatory medication, antioxidant. And so the point is that we should be looking at these medications. It should be done in a randomized controlled trial under a specific study platform, and we shouldn't be writing these things off. So the question is whether or not we should be requiring the high level of evidence that we normally would have in a pandemic or not, and I think that's a reasonable question to have. But these things do need to be studied. They do need to be looked at, but realize at the end of the day, this is just one slice in the large slices of cheese. We can't all depend on that one slice because every slice has holes in it. And the more slices we have, the better. And so as part of my philosophy, if there is something that works, great, that's a slice. But it doesn't mean that we don't do the other things that are important because nothing is 100%.
Dr. Patrick, what are your thoughts on this question?
Well, I do have many thoughts, particularly with the ivermectin being as good as vaccines statement that is very sensationalized and I think is doing a lot of harm because, as Dr. Seheult pointed out, we should study any type of therapeutic that is repurposed, anything we know is safe in humans, and anything that could have even the slightest positive effect on the SARS-CoV-2 virus and COVID-19 illness, because we need everything that we can to fight this. We need multiple, therapeutics, we need vaccines, we need everything. And so I think when you sensationalize something more than the data suggests it deserves, then you have a couple of problems. One, you're misleading people, and that's a big problem. And two, you're getting a sort of knee-jerk reaction from researchers, scientists, from physicians that are going, whoa, wait a minute, something feels a little, off. And so you kind of put off those people that otherwise may be more open to looking at that therapeutic if they otherwise didn't hear a very sensationalistic claim like ivermectin is just as good as vaccines at protecting against COVID-19. And so meta-analysis, Dr. Seheult mentioned a very popular one that was a systematic review and did show some conclusions that were positive, generally speaking. But when you actually go down and look at the individual studies within that meta-analysis and other types of analysis that are aggregating a bunch of data, what you'll often find is a common set of problems. And these problems are manifold. One, they include the co-treatments and the treatments are very different with each of these studies. So for example, sometimes you'll have ivermectin alone. Sometimes you'll have ivermectin plus azithromycin. Sometimes you'll have ivermectin plus some kind of nose spray. Sometimes you'll have ivermectin plus vitamin C and zinc and blood thinners and azithromycin in the kitchen sink, basically. Then you'll compare that to sometimes placebo, sometimes hydroxychloroquine and azithromycin, sometimes doxycycline. And so there's so many variables here that you can't look at just one of the variables and say ivermectin is doing this when you have ivermectin plus the kitchen sink, or you have ivermectin plus something else compared to the kitchen sink, or compared to, so there's a lot of variables that are just being aggregated together that are very different. The second major problem with a lot of these studies is that they are small sample sizes. And so at the end of the day, when you're looking at a clinical endpoint, for example, hospitalization, when you have 50 people in a group, then if 2 people end up in the hospital, so you have 2 people in the control group end up in the hospital, but out of the other 50 people, you have 0 end up in the hospital. So let's say in the ivermectin group, because you'll find studies like this, it's such a low sample size that the the risk of that event happening, the certainty of that event happening being actually, causal by that treatment is so low. Like you can't make a definitive statement about that. And so what you'll see happening is that more and more studies will be pulled together so that you now have larger sample sizes when you pull them all together, and then your certainty becomes a little bit better. But then you have to ask yourself, well, is that really true? When you have such a low sample size within that individual study, pulling them together is kind of a statistical way of manipulating the data in a way, saying, well, look, there's statistical significance when you pull it all together. But, I think that's really important to keep in mind when you're looking at some of these meta-analysis with ivermectin. And then you also have the clinical endpoints varying. So you have people looking at hospitalization. You'll have research groups looking at deaths. You'll have research groups looking at viral clearance, time to a negative PCR. And in some cases, they're all being aggregated together, and it's like clinical benefit is the endpoint. And it's like, well, geez, these are vastly different clinical endpoints. So you really need to be careful when looking at aggregated data. And certainly there's a number of websites out there that are doing this. And I can tell you that I've looked at these individual studies, and in many cases, it's everything I just mentioned and worse, where you can't even find the numbers that they're coming up with. But sticking to just the scientific literature, even that systematic meta-analysis that Dr. Seheult mentioned, if you look at all the different studies, and a lot of them were preprints that they included, the only real consistent finding that was found, consistent meaning every study showed it, was basically time to a negative PCR. In other words, ivermectin and ivermectin plus the kitchen sink, or ivermectin plus whatever, it seemed to lead to a faster viral clearance to some degree. And again, it might be that it takes ivermectin plus the kitchen sink to do it, but that ivermectin plays a small role. We don't really know. And when you take ivermectin plus the kitchen sink, you can't pinpoint it and say it's ivermectin doing it. You just can't do that. It's unless you give the kitchen sink without ivermectin to the control group. And then you can say, well, look, they were given the exact other, array of therapeutics, and they didn't have the same improvement as the other group with the array of therapeutic treatments plus the ivermectin. So there's a lot of nuance to this. And I think that at the end of the day, there is a little bit of a signal. There is something that seems to be going on with ivermectin, whether or not it's in combination with all these other things or by itself. It's unclear. And I think, what is clear is that we definitely do need more data. We need more high quality data. We need more data from, states that are from countries that don't have a really high background of parasitic disease, as Dr. Seheult pointed out. It's a very big confounding factor. But also, we need to not sensationalize something and speak about things that are not true. Like, there's just no evidence that ivermectin is going to protect you from infection and from severe disease as well as a vaccine. There's no evidence of that. And so don't make that claim. Make the claim for what the data speaks to. There may be an effect. There may be an effect, particularly on viral clearance. And so, I think if people would tone it down and not make these grandiose claims, there would be a lot more interest in ivermectin and studying ivermectin. And the other thing to keep in mind is that there's been a lot of people that have now sought out a veterinary form of it, because it is something that, in addition to being used in humans for parasitic diseases and helminths and also scabies and lice and things like that, it's also used in people are calling it horse dewormer, and which, it's not a good idea to go and get a veterinary type of medication and try to treat yourself, because there's vastly, different doses involved. I mean, horses are much larger than humans. And so, it's very dangerous to do something like that. And I think people have sort of heard these sensational claims and started taking their own action and trying to get some form of ivermectin, and really that could be quite dangerous. So I think I agree with Dr. Seheult that we should be studying these repurposed therapeutics, and there is a potential for ivermectin. At least in my opinion, at the very least, it seems as though it's pretty consistently involved in speeding up the viral clearance to some degree. It's not like a huge effect, but there is an effect, and it's consistent with pretty much all the studies that I've personally looked at. So I think that we should really go after that and try to see if that's real, and that's pretty much my thought.
Excellent. And speaking of those studies that you both talked about and these meta-analyses, one argument I've heard for ivermectin is some of these population-based studies where certain countries have decided to give ivermectin on a large scale, and you can understand potentially their motivation. They want to protect their population and prevent COVID-19 if they can, and they're going to use whatever resources they think they have to do that. What are some problems with these population-based studies for people who aren't familiar with what those are?
So basically, they're known as ecological studies. They're great to look at. They're hypothesis generating. But you don't rely on hypothesis-generating studies to determine whether or not somebody gets a medication. What you need to be able to reach the point where you're able to prescribe someone something is what the FDA requires, which is a randomized, placebo-controlled trial that's usually multi-centered, and it's very large. And that's what you have to do to be able to say, this is the medicine that's indicated for this condition. And we just haven't had that yet here in the United States.
And to sort of add to that, Dr. Seheult, I mean, even going back to the original clinical trials with our mRNA vaccines, there were 75,000 people originally in that randomized controlled trial where half the population was getting the treatment, which were the vaccines, and the other half was getting the placebo. And then on top of that, so that's a large number of people, and the sample sizes with this ivermectin is a fraction of that. I mean, a fraction. And on top of that, we now have all this real world data where we've got billions of people worldwide who have had a COVID-19 vaccine, and they are protecting from severe disease. And to some degree, they're also protecting against even getting infected, depending on which, vaccine a person has gotten. So we know they're effective. We know from large numbers. And to sort of even add on to that, everything has changed since the Delta variant. We have had to sort of start again and look at aggregate new data because this is a new variant where our vaccines are not as effective at preventing infection. And the reality is all these meta-analysis and all this data we just talked about with ivermectin, this was not when Delta was the dominant variant. We don't really know what ivermectin even does with the Delta variant. I haven't seen data really showing how ivermectin affects Delta variant.
Yeah, that's a great point. And Found My Fitness, even more than MedCram, we've been talking about things that you can do, things that are easy for you to do, like sleep. We talked about vitamin D. So we're not opposed. I mean, look at our video histories, our respective video histories. We are all in for trying to take control of your healthcare, take control of your life, and to do this. So let's just take the 3,000-foot level here, or the 30,000-foot level. This vaccine is indicated for this particular virus. I mean, I'm not naive to believe that this is the only pandemic that we're ever going to see in our lifetime. It's not the only illness that we're ever going to have to deal with. Some of those other things that we talked about with vitamin D, with sleep, with exercise, stress reduction, fresh air, sunlight, these things have enormous benefits, not just with COVID-19, but every other aspect of our life. And so, again, it's the Swiss cheese model. The more slices you have in there, the better.
100%. I mean, the low-hanging fruit is obviously the things that you can do to improve your lifestyle, making sure your vitamin D levels are high enough, trying to be metabolically healthy, eating the best diet or losing weight if you're overweight or obese, getting a good enough sleep. All these things are hugely important for overall health and certainly for immunity. So again, thank you for pointing that out, because it really, at the end of the day, there are so many factors that do need to be optimized as well.